I invite the last speaker of this session, Professor Fethi Gul. He's a Professor Associate of Critical Care Medicine at Marmara University School of Medicine and Department of Anesthesiology and Reanimation. He's Chief of Critical Care Medicine at Istanbul and a member of the Executive Board of Turkish Society of Intensive Care. He will speak about the current trends in hemoadsorption treatment for surgical trauma and crash syndrome. Please, Dr. Gal. Sir Gal.
Good morning, dear chairs and dear audience. I am very happy to be here, and I would like to express my special thanks to Jafran for organizing these special meetings. Today I will talk about current trends in hemoadsorption treatment for surgical trauma and crash syndrome. And this building is our faculty medicine, especially, and this is the oldest medical faculty in Turkey. The modern education has started at the beginning of the 19th century. Now we have 2 hospitals with 65 ICU beds under control of anesthesiology department. Recently, a huge earthquake with a power of 7.8 struck the southeast of the Turkey and results many deaths. And after this disaster was the worst one that ever recorded in this region, and we take many lessons from this disaster. So we need to know the mechanism of the trauma and associated complications. Firstly, I want to say the danger-associated molecular patterns, which are the main molecule of non-infectious inflammatory causes, influence the systemic inflammatory response syndrome. And after this inducing, and we can see some physiological changes like elevated heart rate, hypothermia or hyperthermia, and also some other physical condition. And what about dumps? If you speak about the trauma, we have to deal about dumps. Dumps are still they are in our body, and they are physiological component of our body, and they stay in endothelium and in mitochondria and in the nucleus also. After trauma, dumps stimulate some receptors which place in endothelioglycocalyx, and these receptors are pattern recognition receptors, and they stimulate the innate immunity. And we know some popular cells about innate immunity, for example, dendritic cells or leukocytes. All these items make a big inflammation. At the end, because of an imbalance, we can see organ dysfunctions. And cardiac surgery recently has become popular and we see many patients with high risks. And also cardiac pulmonary bypass is a stimulus, and it causes a dysregulated immune response like sepsis. And because of these cytokines, we can see compromised microcirculation and elevation of lactate levels, and also occurrence of vasoplasia, and at the end, organ dysfunction, and the renal system also the most affected organ after cardiopulmonary bypass. First, I want to define what is the crash syndrome. And crash syndrome is a systemic manifestation of rhabdomyolysis, and it's caused by a prolonged continuous pressure on the muscle tissue. So crash syndrome includes crash injury and compartment syndrome. It was first described in the Second World War and after a bombing in the London. And 5 people were died because of crash, and they presented in shock and swollen extremities and also with a dark urine. Later, all 5 patients died because of the renal failure. If you look, you can see the acute renal failure incidence is approximately 5 to 35% after the rhabdomyolysis. And its mortality can change and sometimes exceed the 50%. And what is the compartment? It is a closed area with the muscle of a muscle group, nerve and blood vessels, and it is surrounded by a fascia. And its normal pressure is 5 to 15 millimeter per mercury. If there is an increased pressure, and then it can reduce to capillary perfusion, and after that we can see some pathologic consequences. Acute rhabdomyolysis, especially mostly, it occurs by a mechanical injury and by a trauma, and some after trauma, some toxic materials release from the muscle and they insert the circulation, and after that some activation of some channels, for example calcium-dependent neutral protease activation, causes myoglobinuria and necrosis, and after that acute renal failure. If you look, you can see 2 major causes of rhabdomyolysis. The first one is the physical causes, and the other group is non-physical causes. The trauma is the most common type of the physical causes. Also, hypoxia is another important cause of the crash syndrome. And there are some non-physical causes, for example, drugs and toxins, and also infections. Also, some electrolyte imbalances may cause non-physical causes of crash syndrome. If you look laboratory of rhabdomyolysis, only we can say the creatine kinase is the specific parameter for, and it is cornerstone for diagnosis of creatine kinase. At least 5 times more level than normal is diagnostic for the rhabdomyolysis. Also, myoglobin is released into circulation with the creatine kinase, but it has low sensitivity and specificity. So also it has, if it exceeds 100 milligram per deciliter, and it changes the urine color. So for diagnosis of rhabdomyolysis, myoglobin is not enough for criteria. So 5 times upper level of the creatine kinase is enough. Also, we can see some other electrolyte problems. For example, high level of potassium, phosphor. Also, we can see high level of calcium. And what are the complications of rhabdomyolysis? First of all, the most and the worst complication is acute renal failure. Also, we can see disseminated intravascular coagulation. Also, hyperpotassiemia, it is also an emergency state, and we have to be fast at this condition. Also, hyper or hypocalcemia, both of them you can see. And another important issue is hypovolemia. So all these complications should be treated as fast as. And what is the pathophysiology of acute renal failure? Now I will say the contributors. And the dehydration, this hypovolemia, is the most important contributors of acute renal failure. Also renal vasoconstriction, also some cast formation, and some other products. For example, Hem-induced toxicity is also important. Some myoglobin is the cornerstone of the rhabdomyolysis, and it induces renal vasoconstriction, and this is occurred by decreasing the level of the nitric oxide. If the nitric oxide level is decreased, and then you can see renal vasoconstriction. And also other cytokines and some cast cause and distribution of the renal tubes approximately in the proximal renal tubes. After this earthquake, we described some case reports, and in the last year, in the International Intensive Care Symposium, which placed in Istanbul, underground of our society, we decide and we give some examples of crash syndrome. Now I want to give two real patients. The first patient is a 59 years old male patient, and he was under rubble approximately 24 hours. It was transported to our hospital on the second day of accident. At the admission, he was cardiac arrest, and with the rhythm of ventricular fibrillation, we defibrillated and resuscitated about approximately 30 minutes. When we look, we saw that the serum potassium level, phosphor levels were high, and we start the continuous renal replacement therapy immediately. And he was undergoing an urgent surgery for amputating his left leg, which was necrotic. This is important decision of the surgery. And his initial creatine kinase level was 82,000 per unit per liter. And the day after his admission, we start extracorporeal hemoabsorption treatment, and 5 hours, a little longer time, a day for 5 days. And as you see, the creatine kinase level decrease in the times, in the day order, and we stopped the vasopressor treatment in the 3rd day of admission. And we discharged from the ICU on the 25th day of hospitalization with percutaneous tracheostomy. And the second case was a 32 years old male patient. Also, he was extracted after 24 hours of entrapment. He had 15 minutes of cardiopulmonary resuscitation following a cardiac arrest. As you see, the initial levels of creatine kinase, potassium, phosphorus were high. And also we again start CRRT with hemoabsorption filter, and creatine kinase levels also gradually decrease. And also he got free of the vasopressor on the 3rd day and extubated on the 4th day of admission with no any neurological consequences. In discussion, we can say the fundamental targets in crash syndrome management is early aggressive hydration is very important. Also urine alkalization, it is a question mark, but exactly it is still an important issue. Also electrolyte imbalances may be fatal due to arrhythmias, and we should be as fast as possible, and we should start the emergency treatment. Also the surgical management, it is still a question mark. If there is a necrotic tissue, emergency fasciotomy or a debridement of necrotic tissue may be concerned, but we know that the surgical management increased the mortality during the crash. So besides preventing further muscle injury, treatment primarily targets a reduction of these potential nephrotoxic agents, especially creatine kinase and myoglobin, and also correction of the metabolic acidosis and electrolyte disorders. If there is a standard therapy with intravenous fluids, osmodiuretics and bicarbonate may fail. So continued renal replacement treatment may be indicated in further prevent kidney injury and also hemoabsorption treatment. So, and hemoabsorption techniques may absorb molecules, and they which play potentially a role in the pathogenesis of rhabdomyolysis, we can say. And the use of hemoabsorption treatment in our patients with severe traumatic rhabdomyolysis was associated with a significant reduction of plasma concentration. So we can think adjustative treatment during crash and during the trauma patients. And a fifth study, this is a retrospective single center experience. They look, their primary outcomes was the need of the vasopressor treatment. They use intraoperatively hemoabsorption treatment, And the result of this study mainly was the reduction of the vasopressor and inotrope needs. But there is no any difference between the hospital stay or ICU length and also mortality. There is no any difference. And in conclusion, they said it has a better hemodynamic stability with hemoabsorption and a trend of lower mortality, but which was not a statistically meaningful. And here you can see a meta-analysis of use of the hemoabsorption treatment during the cardiopulmonary bypass. They look operative mortality, ventilation duration, intensive care stay, hospital stay, and at the first day of surgery, the inflammatory parameters. If you look, there is no any mortality difference between the groups, but they did subgroup analysis and they saw that operative mortality is decreasing in the non-elective and in emergency condition. And ICU length of the stay decreased in both elective and non-elective surgery, but the hospital length of stay was not different. It is also another important issue. If you look the ventilation duration, they saw that a lower ventilation duration, but this is also was not as significant, and there was no differences if you look ventilation duration. This is also a single center study. It is a retrospective study, 43 patients with 56 years of median age, and most of these patients were male patients. They look and they classified the reason of the rhabdomyolysis, and if you see, you can see the septic shock and infection is the more common reason of the rhabdomyolysis. And if you look, you can see there is a decreased trend of the myoglobin after the hemoabsorption treatment. And also intoxication. Chlorpheniramine is one of the H1 antagonists. They describe this patient and with an elevated level of the creatine kinase, and they start immediately hemoabsorption treatment and renal replacement treatment. You can see here after starting of hemoperfusion treatment, and the creatine kinase level decreased very fast, and after the treatment there is no any long renal failure statement and no chronic renal failure, and this is the case report study. In conclusion, I can say crush injury is a hyperinflammatory state with circulating stocking, and which causing organ dysfunctions. The development of crush syndrome after crush injury is preventable and treatable. The mainstay of treatment is the prevention of renal failure by adequate rehydration and alkalinization of the urine. The combination of therapy of extracorporeal techniques such as hemoabsorption therapies with dialysis seems to promising treatments for crush syndrome. And I want to invite you in the next month. We will have a webinar under Society of Turkish Society of Intensive Care Unit with the collaboration of Jafron. The local time will be 8 p.m. in Turkey. And thank you very much.
Thank you very much, Fethi, for this excellent talk. So we are going to finish this session with an interview of two experts in the field of hemoadsorption.